Okay, so good morning, everyone. After a great start of IAPC Academy 4, last time with Anuja and Karanveer, we have now another second lecture by Gujarat Cancer Center. What I will request, and this is a very important topic again, and we can see that before 6:30 there are already more than 40 participants, and I think all of them are joining fast. Others are joining fast. So before what I will do, I'll request Dr. Preeti, the head of the Department of Palliative Medicine at the GCRI, to introduce both the speakers and moderator, Dr. Kikato and Dr. Bhavna. So Dr. Preeti, please go ahead and introduce both of them, please. Dr. Preeti?
Yes, good morning, madam.
Yes, please go ahead.
And thank you very much. Dr. Kikato is a third-year resident of Department of Palliative Medicine at Gujarat Cancer and Research Institute. Kikato is from Nagaland. He is all India student. He's sincere, hardworking, and truly, what I would say, he's working with me since 2.5 years, and he's truly hardworking. And I think he will be the pioneer of palliative care at Nagaland. He's working on thesis prevalence of delirium in advanced cancer patient in hospice center and outcome after the palliative care intervention. He has 3 publication, and he has also presented I think 2-3 presentation at various conference. Welcome, Kikato. Today's session moderator is Dr. Bhavna Patel. Bhavna is basically anesthesiologist, and she is working at GCRI since 20 years. Bhavna was associate professor in Department of Anesthesia, and then he currently she is associate professor in Department of Pain and Palliative Medicine since 4 years. About Bhavna, she is sincere, hardworking, and she is determined to integrate palliative care and initiate palliative care throughout the Gujarat. Welcome, Bhavna, and thank you. Over to Bhavna and Kikato for today's topic.
Okay, ma'am.
Dr. Bhavna, you can re-log in instead in the meanwhile. Yeah.
Okay, start.
Good morning, everyone. This morning I'm going to discuss on opioids under following heading: opioid definition and opioid receptors, opioid classification, metabolism and metabolite, pharmacokinetics, opioid use in renal and hepatic impairment, common adverse effect of opioids and its management, systemic effect of long-term opioid use, and opioid-induced respiratory depression, opioid-induced hyperalgesia. Definition.
Bhavna ma'am, we can hear you now.
Oh. Thank you.
You want to say something, or should he continue? Bhavna, Dr.
No,
Bhavna?
continue, ma'am. There is a short time and we have too much to discuss.
Okay, Kikato.
Okay. Opioid is a general term that includes naturally occurring semi-synthetic and synthetic drug, all of which produce a binding to opioid receptor, whereas opioid are those drugs which derive from juice of opium poppy, example like morphine, whereas narcotic is a term commonly used to describe morphine-like drugs, mostly in context of a law in some country which related to drug abuse. Opioid receptor, there are 4 opioid receptors: mu, kappa, delta, and nociceptive opioid peptide, NOP, which is not a true opioid receptor. The molecular subtypes include mu1, mu2, kappa 1, kappa 2, kappa 3, and delta 1 and delta 2. It's a table showing different molecular classification of different receptor, endogenous ligand, and sites. Opioid receptor are distributed in various parts of the body, and mostly in nervous tissue, present in both presynaptic and postsynaptic, mostly predominantly in presynaptic. And mu OP is almost molecular classification OP3, endogenous ligand endorphin, site present like peripheral inflammation, pre and postsynaptic neuron in spinal cord, PAQ, PAG, nucleus ref magnus, thalamus and cortex, kappa is endogenous like dynorphin, and spinal cord present supraspinal and hypothalamus. Delta is OP2, endogenous like enkephalin, and present at olfactory center, motor integration area in cortex. And NOP or orphan, molecular classification ORL1, opioid-like receptor, and indigenous like in is nociceptin present in spinal cord. This is figure showing the structure of an opioid. Opioid belong to G protein coupled receptor, family of G protein coupled receptor. Once opioid agonists bind to receptor, conformational changes occur which allow interaction with G protein with subsequent dissociation of its various subunit, resulting in multiple downstream effect. Example in opioid-induced analgesia, G protein is inhibitory and its subunit closes like calcium channel and other ion channel, opens up potassium, rectifying potassium channel, reduces cyclic adenosine monophosphate, thus reducing release of neurotransmitter and nerve impulse conduction, resulting in analgesia. Among all opioid receptor, mu opioid receptor is most important one, and most of the analgesia also are responsible by mu opioid receptor, as well as other undesirable effect of opioids like respiratory depression, reduced GI motility, physical dependence, CNS effect are also mostly mediated through mu opioid receptor. And this is a table showing the functional effect of various opioid receptor affected in different conditions. Like I said, most of them are mediated through mu opioid receptor. Dysphoria and hallucination is mostly by kappa opioid receptor, and catatonia by nociceptive opioid peptide. This is a figure showing different area in the brain and spinal cord and dorsal root, where which receptors are activated during analgesia. Classification of it chemically classified into 4 groups, and phenytoin has a 6-hydroxyl group, and most of the opioid are in this group. Example: codeine, tramadol, morphine, dimorphine, dihydrocodeine, buprenorphine, oxycodone, no. Benzomorphine, pentazocine, and loperamide, phenylpiperidine as fentanyl and pivydine, diphenylheptane as methadone, tetropropoxyphene. According to receptor, is also classified into 4 groups: agonist, partial agonist, agonist, misagonist, and antagonist. Where an agonist has an affinity and binds to cell receptor, it induces the changes in the cell that stimulate physiological activity. As such, there is no gasoline effect to analgesia. Example like fentanyl, morphine, methadone, oxycodone, etc. Whereas partial agonist has a low intrinsic activity, so its dose response curve will exhibit a silent effect. Example: buprenorphine. Antagonist group of drugs do not have an intrinsic pharmacological action, but it can interfere with action of an agonist. Example like naloxone, naltrexone, naldomidine. Misagonist and antagonist. This group of drugs like act as an antagonist in one receptor and as an agonist and another receptor. Example: butorphanol, nalbuphine, and pentazocine. Another group is as a mixed mechanism of action, which include tapentadol and tramadol, by affecting both the mu opioid receptor and also monoamine inhibitor. Metabolism of opioids. Mostly, most of the opioids metabolism occur in liver, involved in phase 1 and phase 2 reaction. Phase 1 reaction Among phase 1 reaction, oxidation, which is catalyzed by the member of cytochrome P450 enzyme system, is the most important, followed by phase 2 reaction, usually involve conjugation. This may be in form of like glucuronidation, sulfation, methylation, acetylation, etc. This is table showing individual drug metabolism, reaction, and excretion. I'll highlight a few drugs like morphine, undergo glucuronidation, sulfation, and dealkylation, mostly excreted in urine as 10% unchanged and 70% as glucuronide. Traces are found in feces, and codeine also mostly excreted in urine, 86% as unchanged to 5 to 10% and 60% as codeine glucuronide, and 5 to 15% as a morphine, which also contribute to its analgesic effect and traces in feces. Buprenorphine is mostly excreted unchanged in feces, and 2 to 3 as 70% and 2 to 3 13% as in urine. Methadone is excreted 60% in urine and 30% in feces, and fentanyl 70% in urine and 9% in feces. Both methadone and fentanyl, the metabolites are inactive. Pharmacokinetics of opioids. All opioids are weak bases. They have a large volume of distribution because of a high lipid solubility, and there are a few factors which affect the pharmacokinetics of opioids, including age. As age increases over the age of 65 years, both hepatic and renal function decline. Such opioids can have a central increase in central nervous sensitivity. Also in hepatic disease, different mechanism which may lead to increased bioavailability or impaired metabolism, and also increase in free unbound drugs. Renal failure, active metabolites may get accumulated. Obesity is a large volume of distribution and it has a prolonged elimination to have. And other conditions like hypothermia, hypotension, hypovolemia, they may also contribute to variable absorption, distribution, and metabolism of drug. This is table with showing different pharmacokinetics of an individual drugs along with equianalgesic, comparing the equianalgesic dose of 10 mg IM morphine, their bioavailability, their onset of action in hour, and the plasma half-life in hour, peak effect in hour, and duration of action, and also their active metabolite. I'll mention few, like morphine, the oral bioavailability ranges from 12 to 84%, average of 30%, plasma half-life 2 to 3 hours, and its peak effect at 30 minutes to 1 hour, and has a 3 to 6 hour duration of action. Its active metabolite is morphine 6 glucuronide. Oxycodone, orally, it has a 35 to 80% availability, and T-half to 2 to 3 hour. Duration is same as similar, 3 to 4 hour, and active metabolite is hydromorphone 3 glucuronide. Methadone orally has a 60 to 90% bioavailability. It has a varying long half-life, varying from 12 hours to more than 150 hours, like 6 to 7 days, and peak at onset of action to 4 to 8 hours if there's no active metabolite. Buprenorphine, when used as an oral, 15% bioavailability, sublingual as 50%, and IV as 100%. Codeine, oral bioavailability is 60 to 90%. Also, T-half is 2 to 3 hours, and duration of action 3 to 6 hours. Active metabolite is morphine. Fentanyl, when used in buccal, 25% oral buccal bioavailability, and when used transdermally, 90%. IV, when used IV, duration of action is 1 hour, and active metabolite as in norfentanyl. When used as a transdermal, T-half varies from 13 hours to 22 hours, and duration of action lasting from 48 to 72 hours, has no active metabolite. And tramadol orally, it's 65 to 75% bioavailability. It has an Active metabolites is all-this methyl tramadol. Estepentadol oral is 30%, and T-half 4 hours for IR release, and 5 to 6 hours for MR release. Whereas duration of action is 4 to 6 hours for immediate release and 12 hours for modified release. Active metabolite is estepentadol or glucuronide. Opioid use in renal impairment. Renal impairment or a failure will affect metabolism, including like absorption, distribution, metabolism, and elimination. In kidney insufficiency, drug dose adjustment become necessary in order to avoid accumulation of an active metabolite and which increases an adverse effect, while also trying to maintain the efficacy of the drug. In chronic CKD, like creatinine clearance can guide in use of an drugs in various different type of opioids. In mild to moderate renal impairment, strong opioids with active metabolite like codeine, morphine, hydrocodone, oxycodone, tramadol can be used with caution, whereas in severe renal impairment, strong opioids which do not have an active metabolite can only be used, like fentanyl, buprenorphine, and methadone. Current practice goes from progression from tramadol, and if no relief, to hydromorphone or oxycodone, and if no more relief with distinct, then can go to fentanyl or fentanyl. Generally, opioids which are considered as safe are L-fentanyl, buprenorphine, fentanyl, and methadone, which can be used cautiously, include like oxycodone, tramadol, hydromorphone, and avoid, if possible, include morphine, codeine, diamorphine, and dihydrocodone. There is a dose recommendation in kidney insufficiency using creatinine clearance, like morphine can use 75% of a usual dose if creatinine clearance is 10 to 50 ml per minute, or up to 50% of the usual dose if creatinine is less than 10. In some states, it's better to be avoided if creatinine clearance is less than 10. But when using, better using short-acting preparation rather than modified release, and also increasing the period of dosing interval. During dialysis, metabolite can accumulate between dialysis session. Therefore, careful dose monitoring is required both during and after dialysis. And when safer alternatives are available, morphine and codeine, which lead to metabolite accumulation, should be avoided, whereas fentanyl and methadone appear to be safe because these metabolites are inactive. Opioid is used in hepatic impairment, like in liver dysfunction, unlike renal, where creatinine clearance can guide for dosage of individual drug. But here in hepatic impairment, neither the type of liver damage nor its severity or laboratories can correlate with individual drug kinetics, and such no general rule are available in modifying drug dosage and guidance. As such, following factors should be considered whenever we are studying opioids, like extent of the liver disease and involvement of hepatorenal syndrome, extent of individual drug metabolism and elimination by liver or extra hepatic site elimination, and route of administration. Generally consider safe opioids in hepatic disease like fentanyl, which can be used cautiously, includes buprenorphine, diamorphine, and morphine, and avoid, if possible, is like codeine, methadone, oxycodone, tramadol. Is a dose recommendation in liver insufficiency, like morphine, either reduce dose or increase frequency, example like morphine, and methadone can be used, but should be used carefully and doing also slow dose titration used by specialists. Common side effect of an opioid, like infecting GI, like nausea, vomiting and constipation, autonomic postural hypertension, giddiness, central nervous system, drowsiness, and sedation. mention is a few mechanisms of action and management. Opioids produces nausea and vomiting through both central and peripheral mechanism. It stimulates the medullary CTC, increase vestibular sensitivity, and alter effect on gastrointestinal tract. Management, usually tolerance to nausea and vomiting develop in 7 to 10 days, and prophylactic anti-emetic prescription is not necessary unless there is a history in those patients who have a severe opioid-induced nausea and vomiting. However, those who are studying opioids, anti-emetic can be prescribed on PNR basis. And haloperidol and metoclopramide is preferred over other antiemetics. For long-term antiemetic administration, opioid reduction would be an alternative good choice. Constipation, all opioids causes constipation, and constipation tolerance either develops slowly or not at all. And it's the severity of constipation does not seems to be related with dose. Management involve treatment with begin with contact or osmotic cathartic like bisagodol, sina, sodium picosulfate, or polyethylene glycol. Where bulking laxative should not be used in debilitated patient or living with poor oral intake, as it can exaggerate constipation. If fallen measure is not improved, like use whenever available Pomara, peripherally acting opioid receptor can be used. For example, like methanetrozone, dosage according to your weight, naloxone, like 25 mg once daily, and naldimetine, like 200 microgram daily. Postural hypotension, like opioids causes vasodilation, decreased sympathetic tone, vagus nerve mediated bradycardia, histamine release, and causes decrease in systemic vascular resistance and decrease in blood pressure. This can rarely lead to edema, hypotension, postural hypotension, and syncope. As such, patient care should be there to avoid fall injury. Early opioid reduction might require sedation and drowsiness. Like most of the patient might develop sedation, to some extent sedation and drowsiness during initiation of opioid therapy or during dose escalation. In case other co-founding factor has been eliminated, and if it continues to persist, then management include using psychostimulant like amphetamine and amphetamine-like agent like methylphenidate, dextroamphetamine in 2.5 to 5 mg in the morning, maximum up to 40 mg per day in divided doses, or modafinil 100 to 200 mg per day, maximum 600 mg per day. Other adverse effects, which are less common, include in central nervous system like hallucination, myoclonus, respiratory depression, confusion, delirium, autonomic like xerostomia, urinary retention, cutaneous like pruritus and sweating. Cognitive impairment, mild cognitive impairment is common following initiation of opioid therapy or increase in dose. It may further progress to disorientation, restlessness, agitation, hallucination, and delirium. Stepwise approach to management include discontinuation of non-essential centrally acting medication if patient is on, or if analgesia is satisfactory, reducing the dose by 25%, excluding other causes like sepsis and metabolic derangement, CNS involvement. And if delirium persists, opioid reduction can be done, or changing opioid route like intraspinal route, or trial of other medication like local anesthetic or interventional approach, and also trial of neuroleptic agent. Multifocal myoclonus, all opioids analgesics can produce myoclonus. Mild and infrequent is common, but occasionally this may cause a disturbing breakthrough pain. Management include dose reduction and symptomatic management, mainly with favorably with benzodiazepine, particularly clonazepam or midazolam, or anticonvulsant like gabapentin. Xerostomia, exit mechanism is unclear, but it has been proposed opioid causes decrease in salivary production and secretion through its effect on central nervous system and autonomic nervous system. Management include adequate hydration, artificial saliva stimulant, and in some study, pilocarpine has been successfully used in treatment of an opioid morphine-induced xerostomia. Urinary retention can particularly occur in elderly male patient due to its opioid because opioid increases the sphincter tone. Tolerance usually develop, and in case of in rare cases, management can be done by catheterization, which usually improve. Pruritus is also an infrequent adverse effect of chronic systemic opioid therapy. Mechanism is not clear. Some opioids like morphine can generate histamine release from the mast cell, whereas others have suggested the mechanism which has been mediated through central mu opioid receptor. Benefit has been reported with non-sedative antihistamine and gabapentin. Others include opioid reduction and also ondansetron have been tried in opioid-induced pruritus. Systemic effect of an opioid involve physical dependence or addiction, osteoporosis and increased fracture risk, endocrine effect like obesity and diabetes, influence on neoplastic transformation, immune effect, infection, cardiovascular complication, sleep quality and disturbance in opioid-induced bowel dysfunction. I'll discuss few in possible. Like physical dependence is defined when there is an occurrence of withdrawal symptom after either abrupt dose reduction or stoppage of opioid agonist or administration of an antagonist. Symptoms include like anxiety, irritability, salivation, lacrimation, sweating, nausea and vomiting, diarrhea, etc. Abstinence, or this is called abstinence symptom, which usually appear within 6 to 12 hours and reach peak at 24 to 72 hours. To prevent this, usually dose required is 50 to 75% of the previous daily dose. Dose can be gradually titrated down until the drug is discontinued. Addiction, whereas addiction is a primary chronic disease defined by one or more of the following behaviors, like impaired control over drug use, compulsive use, continued use despite harm, and craving. Mechanism of addiction is complex and depend on both internal and external factor to the individual. This is a patient population who are at the risk of addiction potential, abuse, and diversion. Like patients with a chronic post-treatment pain syndrome have a higher addiction potential and also abuse potential and diversion potential. Osteoporosis induced fracture risk. This mostly phenomenon is may be related to hypogonadism and also mu receptor, but also maybe due to mu receptor related inhibition of osteoblast activity and interference of opioid with bone turnover. Higher risk of fracture has been confirmed for a number of opioids like morphine, oxycodone, tramadol, and codeine. According to some study, the risk of fracture was found to be higher in first 2 to 3 weeks of treatment, which give a suggestion that this association of event was mostly due to sedation and dizziness initially caused by opiates. Endocrine effect. Opioid increases level of prolactin, decrease level of sex hormone, and infrequently causes secondary adrenal insufficiency. Chronic opioid therapy may contribute to hypogonadism with manifestation of sexual dysfunction, infertility, fatigue, accelerated bone loss, and mood disturbance. Women may suffer from amenorrhea, oligomenorrhea, vaginal dryness, and hot flashes. Management in appropriate clinical situation when there is no contraindication. Replacement therapy may be reasonable, like in men typically treated with transdermal formulation of testosterone, and premenopausal women may be treated with estradiol. Endocrine effect, chronic use, particularly chronic opioid use, particularly in a setting of substance abuse, and its treatment is associated with weight gain, hyperglycemia, and worsening of diabetes. This may be because of central action via sympathetic nervous system and impair insulin secretion. However, in contrast to other opiates, methadone and tramadol may be associated with a symptomatic and even fatal hypoglycemia. Hardly opiate therapy may require in in abnormal glycemic control. Influence of neoplastic transformation. Multiple experimental studies have shown that opiates can promote process of angiogenesis, proliferation of cancer cell, adhesion, infiltration, and also formation of distant metastasis. Whereas some have demonstrated a potentially protective effect of some opioid in cancer, like in methadone, has been shown to induce apoptosis of leukemia cell and increase sensitivity of some cancer to chemotherapy. Opiates and immune. Opiates by either directly binding to opioid and toll-like receptor, or indirectly via activation of hypothalamo-pituitary axis and sympathetic nervous system. Opioid seems to suppress immune mechanism by release of glucocorticoid catecholamine from adrenal medulla, and also catecholamine and neuropeptide Y from sympathetic nerve, which innervating lymphoid tissue. As such, in some studies, morphine reduces NK natural killer cell, T lymphocyte proliferation, and monocytic and macrophage function and cytokine release function, leading to host vulnerability, immune resistant vulnerability to other infection. However, in contrast to most of the opioid, tramadol appear to have an intrinsic immunostimulatory properties, which may be related to its serotonergic activity. This potential consequence of opioid-related immune suppression include increased susceptibility to infection, increased risk of this serious complication has been revealed in number of epidemiological studies, and from these studies, the risk was found to be highest during the first 2 to 4 weeks of treatment. Opioid use, which are predominantly used as non-medical, is a frequent in HIV infection patient, and based on experimental study, it appeared that mu opioid agonist has potentiated HIV replication, and it also associated with higher viral load and lower CD4 cell count. Cardiac complication. Secondary to vasodilation and reduction of cardiac output, opiates may cause hypotension, orthostatic hypotension, pulmonary edema, and syncope. Opiates also produce sinus bradycardia, supraventricular tachycardia, and impair atrioventricular conduction, prolonged QT interval, with risk of torsade hypotenuse, which has been found to be highest with methadone use. All these actions are mediated by activation of peripheral opioid receptor as well as opioid independent mechanism, like including histamine release mediated by morphine. Opioid may also enhance the hypotensive effect of antihypertensive drug, and higher dose of opioids were associated with higher risk. Influence of opioids on sleep and sleep disorder breathing. Opioid treatment impairs sleep quality, sleep architecture, and also contribute to daytime fatigue and sleepiness. Because of its suppressive effect on respiratory rate and tidal volume, as well as hypoxic and hypercapnic respiratory drive, opioid use may lead to a spectrum of respiratory derangement during sleep, including hypoventilation, hypoxemia, irregular breathing, and apnea. Opioid may induce sleep disorder breathing, mostly of central type, because of its influence on opioid on breathing rhythm and control of ventilation. Opioid can also either exaggerate, trigger, or exacerbate obstructive sleep apnea. Opioid-induced bowel dysfunction. Opioid affect bowel function through binding of a peripheral receptor, spread throughout the GI tract. Constipation occurs in above 40% of an individual using opiate, and GI pseudo-obstruction may develop as a serious consequence. Narcotic bowel syndrome is a condition where patients receiving opioid for the treatment for pain actually become more sensitive to painful stimuli and experience worsened abdominal pain with escalating opioid doses and improvement after cessation of opioids. Mechanism have been maybe due to increased segmental motility or opioid-induced hyperalgesia. Opioid-induced respiratory depression. Respiratory depression is mediated mainly via mu-opioid receptor. This mu-opioid receptor is present in brainstem, medulla pons, in cortical area, thalamus, and to lesser extent in peripheral carotid body. GBG-dependent activation of GRK channel result in decrease in the sensitivity of the respiratory center to arterial PCO2 and inhibition of respiratory rhythm generation. Respiratory depression is always accompanied by other signs of CNS depression like sedation and mental clouding. Mechanism explained like mechanism involved is like decrease in sensitivity to respiratory center to arterial PCO2. Like normally changes in PCO2, these are dictated by chemosensitive neuron present in brainstem and medullary nuclei. Increase arterial CO2, which results in compensatory increase in a minute ventilation rate. As opioid is having a depressant effect on hypercapnic response, minute ventilation won't increase or will be insufficiently increased in response to increased CO2. Another is inhibition of a respiratory rhythm generation. Maker of respiratory originate from pre-Bozinger complex within the ventral respiratory column of medulla, as mu receptor are abundant in this region. Local injection of opioid agonists is shown to decrease respiratory frequency. Management involve maintaining airway, administer oxygen, discontinuing the opiates, and obtaining IV access and administering naloxone. In severe cases, severe life-threatening condition of respiratory depression, if the patient is bradypneic but readily erosible and the peak plasma level of the last opioid dose has already been reached, the opioid should be withheld and the patient monitored until improved. But if in case severe hypoventilation occur or patient is bradypneic and unerosible, naloxone should be administered. Doses start from 400 microgram IV and then increase the dose to 800 microgram, can be given up to 2 to 4 microgram. Like each dose should be given over 30 seconds. Assess the patient after 1 minute, and if no respiratory response or respiratory improvement, increase the dose as been mentioned. And in case if the patient there is a severe respiratory depression but it's not life-threatening condition, then lower dosage can be used, like as low as 100 microgram IV and repeat every 2 minutes till respiratory rate improve. Even as low as 20 microgram IV every 2 to 4 minutes can be used. Another is nasal spray. Naloxone nasal spray has been available, and in case it can be used as a 1 puff in 1 nostril and wait for 2 to 3 minutes. If no improvement, then give another nostril or 1 puff. In case if respiratory depression is due to buprenorphine, because buprenorphine have a higher receptor affinity binding and also receptor binding for prolonged time, so higher dosage of naloxone is required to reverse buprenorphine induced respiratory depression, like 2 mg IV over 90 seconds and continuous 4 mg per hour continuous IV infusion can be given. As naloxone can precipitate a severe abstinence syndrome, so it should be administered only if strongly indicated. In case if a patient is comatose, intubation to prevent aspiration. After ongoing treatment involved like monitoring of consciousness and respiratory rate every 15 minutes for 2 hours, and this should continue every hourly for 4 hours. Another for 2 hours if it's immediate release tablet of opioids, and another orally for another 6 hours if it's a modified release, and another after 24 hours if it is a use of methadone. Opioid-induced hyperalgesia is characterized by paradoxical worsening of a pain among patients treated with opioid analgesic therapy, which is further exacerbated by dose escalation. It can be occur in both acute and chronic pain and appear to result from sustained sensitization of nervous system. A possible underlying mechanism is activation of glial cell via toll-like receptor, which play an important role in inflammation, pain signal transmission, pain hypersensitivity, and opioid tolerance, or activation of an excitatory pathway like aminal cyclase and cyclic AMP increase, which result in greater protein kinase activity and also activation of NMDA receptor, or increased nociceptive activity in primary afferent sensory nerve, and in microglia, P2X4 is a upregulation of P2X4 ATP sensitive channel. Clinical feature: in case of a surgical pain, may contribute, OIH may contribute to exaggerated level of pain in immediate post-operative period and also development of a chronic pain state. Whereas in cancer patient, it may manifest in various ways, like rapidly developing tolerance to opioid, short-lived benefit from increased doses, or change of pain pattern. However, OIH is not limited to very high dose or any particular opioid, is probably underdiagnosed and more common than generally thought. And severe pain that does not respond to increased dose of an opioid or is complicated by severe undesirable effect should raise the possibility of OIH. Differential diagnosis include opioid tolerance, which can be differentiated by relieving of pain by increasing the dose, de-risk patient and progression of an disease. Management include a multimodal approach of analgesia, including paracetamol or NSAID and other adjuvant, progressively and rapidly reducing the dose of a casual opioid to about 25% of a peak dose, switching or rotation of an opioid, and if OIH occur at a very low dose, then opioid can be discontinued. Also use of an NMDA receptor antagonist like ketamine and methadone may also be a good choice, especially the weak NMDA antagonist. Thank you.
Nice presentation, Kikato. Am I audible? Hello.
Dr.
Hello.
Bhavna, yeah, you are audible and there are questions. Please, yeah, go ahead.
Good presentation, Kikato. You have covered everything. As we all are practicing palliative care physician, every resident must know details of opioids, opioid metabolism, their effects on different systems, so that choice of drug can be predicted well. Everyone should know about adverse effects, side effects, and its management. Ma'am, there are a few questions.
So the first, yeah, go ahead with the questions. The first,
like which are the currently approved and available in India? Many opioids, tramadol, tapentadol, mild opioids, tramadol, tapentadol, buprenorphine, strong opioids, morphine, fentanyl, and methadone. These are available in India. Ma'am, anything to
they
add?
are asking, the question is, what are the opioids available in ENDs, essential narcotic drugs?
Yes.
So any residents who is joining wants to answer this? There are 6 opioids that is approved by END. So anyone who wants to answer? Any resident?
Lekha, have you joined?
Because somebody should answer this.
Yes, ma'am. Morphine, fentanyl, methadone, hydrocodone, oxycodone. Recently, tramadol also had been approved.
Excellent. Because you are not audible properly. There are 6 opioids approved in ENDs. So, Neetu, can you repeat it properly?
Ma'am, morphine, fentanyl, methadone, oxycodone, hydrocodone. Recently, tramadol also.
6 opioids are approved by Government of India as essential narcotic drugs, but although they all 6 are not available, only 3 are available for pain management. So there is one more question, Dr. Bhavna.
Hypoglycemia. Where is that? Opioids are hardly required in deranged hypoglycemic condition. There is not opioids are hardly change in opioids is hardly required. We can go with whatever patient is taking. Need not to change when there is deranged hypoglycemia, hypoglycemia or hyperglycemia. Is it right now?
There is a question, how does gabapentin helps in for pruritus and what is the dose? Would you like to answer, Kikati? How does gabapentin helps in pruritus?
Theory says there is no certain mechanism, clear mechanism, and it is said to be helpful. And there is not any. We couldn't found anything.
Basically, it is important to learn because opioids are important medication for anywhere in the pain management as well as a palliative care physician, and it is important to learn their mechanism, their actions, how they work, and what are the basically the side effects. So it's not that side effects, by learning side effects we are not going to use it, but which opioid should be preferred on at what time, based on the side effects and based on the parameters or renal parameters or liver function test. Also, this is a good exercise, and I think we should all know about the pharmacokinetics and pharmacodynamics of opioids, which we are using every day in a everyday practice. So, if there are no questions, there is one more question, I think. What is the question? Let me see. This is just an compliments to your lecture. So Archana will send you all the compliments, and you did well. You tried to explain and you tried to make it it's like as best as possible. You have tried that, although you know many of the mechanism of action and are still not clear, but you have tried your level best to explain it very well.
Ma'am,
Thank
there
you
is
very
one
much.
question.
To provide
Yeah,
main reference utilized. I think Kikato, Dr. Lekha, you have used Oxford Medicine textbook of palliative care.
Ma'am, there is one question. It says, should we write a narcotic prescription form for tramadol?
So it is still not very means like many other pharmacists, they are giving tramadol on your normal prescription, like in a hospital card or something, but prescription is required. But DD form, if you are asking, still not, it is not, I don't think it is required. We are writing on the card itself. Although in 2018 they have tried to include in the essential narcotic drugs, but it's not freely available in the market, but it is available on prescription. Any other questions?
Nothing, ma'am.
Okay, then see you next week with again a lecture by Tata Memorial team. Thank you very much, Dr. Bhavna and Kikato for your presentation and for your making this. It's like it is an informative presentation, and a lot of things. It is required for all the residents that they should know all these basics about the opioids. Thank you very much, and thank you, Dr. Preeti. Thank you, Nisha and Archana. We will see you next week before 6:30 on Monday. Have a nice week.
There is one question that's just come in. It says,
Okay.
can we start both tramadol and morphine together?
Would you like to answer, Dr. Bhavna?
We can't prescribe both together, as both will compete to each other. Tramadol, we must have to stop tramadol if we start morphine.
So, we should not prescribe tramadol and morphine together. And I think, Divya, you should go and read the mechanism of action, that why can't we write tramadol and morphine together. We should not write these two medications together. Kasha पूछ रही है, should we write a narcotic prescription? Okay, we have dealt with this question. Okay. Okay then, thank you very much.
Thank you, ma'am. Thank you, ma'am, very much.
Dr. Bhavna, and thank you everyone for joining early morning. Next week we will see you again on Monday before 6:30.